Poison ivy, like its buddies poison oak and poison sumac, has an oil called urushiol. When this oil touches your skin, tiny chemicals creep in. They're really small, and your body probably wouldn't think much of them, but they bind to skin proteins. An inquiring cell with octopus arms called Langerhans, or antigen-presenting cells, APC, grabs the protein with the poison ivy chemical because now it thinks the body is being invaded by a foreign substance. So, it needs to send a signal. The APC rushes from the skin to organs called lymph nodes to sound the alarm of a pending invasion. There they meet up with T cells who are ready to help and expand into an army that's prepared to meet a poison ivy urushiol invasion. These T cells move back to the skin to watch for urushiol. Some people, about 10 to 15%, seem to be resistant to the allergic effects of urushiol, but even these people may eventually develop the allergy. If you're allergic, however, the next time your T cells see the signal again, they react by sprinkling out proteins called cytokines and chemokines, some of which reach your bloodstream. This causes a cascade of events leading to itchiness and swelling. They also recruit cells called phagocytes, such as neutrophils and macrophages, that eat up and remove debris, cell assassins called cytotoxic T lymphocytes and natural killer cells, and more helper and memory T cells. All of these cells send more signals that draw more cells. The overall effect is like a faucet being turned on high. The killers destroy the urushiol-bound tissue, but collateral damage occurs and healthy cells can also be killed. Your skin turns red and blisters fill with fluid as the deluge of cell killers continues. Your reaction will depend on how susceptible you are to urushiol, how much oil has gotten into your skin, and how much you've been exposed to poison ivy in the past. The chain of events is complex and it takes time. In fact, it could be 48 hours before you develop an itchy rash and blisters. If exposed, you can minimize your allergic reaction by scrubbing your skin with soap and water as soon as possible. Because it's an oil, urushiol can get on your clothes, tools, or pets and can touch your skin later with the same nasty effect, so carefully wash those too. Of course, the best thing is to avoid poison ivy, oak, or sumac in the first place.
This is where I used to live for 6 years before I joined the EIS class of 2016. It was beautiful, but it was also very remote. And I learned some things by living in such a rural area. For example, did you know that Amazon will call you to ask if your address really exists? I also thought it was no big deal to go 180 miles round trip to pick up some organic fruit at the Gallup Safeway, or travel 336 miles round trip to eat at my favorite cafe in Flagstaff, or load up the car to go 460 miles round trip to pick up my parents at the Albuquerque airport. Did anybody guess my previous location based on my geographic hints? So bonus points if you guessed Chinle, Arizona, in the Four Corners region of the United States. I lived right in the middle of the Navajo Reservation when I had the great privilege and honor to be a physician at Chinle Hospital. I loved living in Chinle, but small town living can be challenging. For example, I used to dread going to the grocery store to buy ice cream because I worried that I would run into one of my patients with diabetes and they would raise their eyebrows at the hypocrisy in my cart. I also got to experience the rumor mill each time I gave birth at our small hospital. I must have had at least 10 visitors within the first hour of my first son's birth. I got beautiful gifts like this handmade cradle board, but as you can see from the picture, I was exhausted. These rather minor inconveniences gave me just a tiny window into the complaints I heard from my small panel of patients living with HIV. I'm going to share some stories about people I met, but I've changed their names and identifying information, and I'm not showing any actual images. One of my patients worried about getting his lab drawn at the only lab in town because he had a family member working there. Another man worried about getting his prescriptions filled at the only pharmacy because an ex-partner worked there. I took care of a patient I'll call Kevin, who had an HIV drug resistance pattern that we typically only see in large cities. He had a prominent position in his community, and he was traveling the 584 miles round trip to Phoenix to meet anonymous sex partners online. I also took care of Tyler, who didn't have enough gas money for transportation to a larger town, but he was using a sex app to meet men in and around his small community. As a clinician, I cared deeply about each of these men, not just about their HIV viral load and medications, but about what it meant to be a member of a marginalized population living with a stigmatizing infection in a small community. I wanted to do more for them. I wanted to prevent HIV infection in other men who have sex with men. But I didn't quite have enough information or knowledge to think about their plight on a population level. So I joined EIS. So this is a grainy picture of me on the first day of EIS conference when I was an incoming officer. I think I look pretty nervous about the upcoming match process. But becoming an EIS officer was a way to shift my expertise from improving individual lives to improving the health of populations. I joined the Division of HIV/AIDS Prevention, seeking answers and new skills to better help these patients and other men like them. I hit the jackpot when I got to travel to New York City on an EpiAid to expand access to HIV pre-exposure prophylaxis, or PrEP. I was wowed by their glitzy, sex-positive media campaign. PlaySure ads were plastered all around the city. The health department even distributed these PlaySure kits. They included high-quality condoms, lube, and a compartment to store your PrEP or your HIV medication. I got to meet Ben, who came to a community advisory board meeting with the LGBTQ+ advisor from his school. Ben shared his opinion about how we could increase PrEP awareness among other young, gay, African-American men like himself. I left that meeting feeling so optimistic about how Ben could prevent himself from being infected with HIV. He had access to New York City's sexual health clinics and could even receive free PrEP through Medicaid or other city subsidies. His state has committed $5 million to end the AIDS epidemic, and his future is looking bright. Later in EIS, I had the opportunity to investigate an increase in HIV, mostly among MSM, in rural West Virginia. Those country roads felt like they were taking me home to my small-town physician roots. But it was humbling and heartbreaking to hear the stories of the men in this investigation. I met Andy, who told me that the waiting room of his HIV doctor's office felt like a fishbowl, and he worried that people would figure out his diagnosis and beat him up. He and the other men I met all said that they were not comfortable going to a local health department to get HIV testing because they worried about the stigma they would face even just in the waiting room. Sam had the same primary care doctor for 10 years, and he was never asked a sexual history or offered an HIV test. William was initially suicidal after learning of his diagnosis, but he worked with his Ryan White case manager to embrace his diagnosis and educate his friends and roommates. In fact, he even invited his case manager over for a pizza party, and together they taught basic HIV facts like you can't get HIV from sharing a toilet seat, and shaking my hand will not give you HIV. He also took an amazing next step and educated his friends about PrEP, and he even convinced 2 of them to ask their primary care doctor to start them on it, and she did. We had many conversations with medical providers during this investigation. Most were not disapproving of men who have sex with men, but a few were. And the challenge for gay men living in rural West Virginia is that they had no way of telling which places were safe to disclose their true sexual history. We brainstormed with them, and we brainstormed with the medical providers. Some providers were open to the idea of displaying a rainbow flag in a window or on an ID badge to indicate that this was a safe space. This small gesture does not solve the small town problem of being seen by nosy neighbors while you're sitting in a busy clinic waiting room, but it's a start. While stigma cannot be changed overnight, I was encouraged by the innovative use of technology to increase HIV prevention efforts in rural West Virginia. The West Virginia Department of Health and Human Resources partnered with CDC to create a geo-targeted HIV testing advertisement that showed up on sex apps when people were located in the zip codes included in our investigation. The most exciting part about this innovation is that it worked. Tim told us that his friends saw the advertisements and decided to get tested. We still need to remove more barriers to HIV testing in small towns. We brainstormed strategies like home HIV test kits or meeting a person in a discrete location to perform a field HIV test. These small town challenges might just breed innovations that could change the direction of HIV testing. My experience in the field of HIV has shown me that MSM living in rural areas face very different challenges than MSM living in cities with access to more resources. But I feel hopeful that if the HIV prevention community starts paying more attention to the unique circumstances for rural MSM, we can find creative, innovative solutions to end the HIV epidemic, even in the most remote corners of the country. Thank you.
On September 4, 2012, CDC released its 25th issue of Vital Signs, a monthly call to action concerning a single important public health topic. This report focuses on the issue of blood pressure control. In the United States, more than one-third of the adult population, or approximately 67 million people, have high blood pressure. Of those with high blood pressure, more than half don't have it under control. High blood pressure makes you 4 times more likely to die from a stroke and 3 times more likely to die from heart disease. What is high blood pressure and how do we improve control? Normal blood pressure is where your systolic pressure, or the top number, is less than 120. And your diastolic pressure, or the bottom number, is less than 80. If you are below this level, make sure you check your blood pressure at least twice a year. If your pressure is 120 to 139 over 80 to 89, you should monitor it closely and make healthy lifestyle changes. If you have a pressure of 140 over 90 or higher and you are not already being treated for high blood pressure, seek medical attention. If you are being treated, make sure to take your prescribed medicines. Ask your healthcare provider to check your blood pressure during visits, or to check your own pressure, you can buy a blood pressure cuff. You can even get checked for free at many fire stations and pharmacies. High blood pressure has few warning signs. Don't wait until it's too late to control your pressure. Get your blood pressure checked regularly. Remind your healthcare provider or your pharmacist to talk to you about your pressure and know the warning signs. Be physically active. If you smoke, get help to quit. Practice other good health behaviors. And take prescribed medicines as directed. High blood pressure is within your control.
If there's a mystery disease out there anywhere in the world, people generally send those samples to the Special Pathogens Branch to help them figure out what it is.
The fear of Ebola is spreading in Uganda.
We have 101 cases. Out of this, 22 have died.
The virus is transmitted through bodily fluids. It has so far been found mostly in western Uganda's Bundibugyo district.
Well, when CDC responds to an outbreak, typically we'll meet with the Ministry of Health and with other non-governmental organizations to figure out where we fit into the puzzle, and we really take our lead from the Ministries of Health.
When in an outbreak situation, you kind of have to quickly pack up. You have to really know what you're going to need, and that's why we kind of have established, okay, how much are we going to need to run 500 samples, say?
We're involved in setting up laboratory diagnostics on site, or at least in the near proximity to the outbreak itself.
And so on a day-to-day basis, we would get specimens, taking them into a makeshift hot lab.
Being the laboratorian, you're the first person to actually see the results, and you know firsthand if it's positive or not.
To characterize an outbreak, we typically want to know the total number of confirmed cases. And that involves really going to do community surveillance if it's a wide area, to have town meetings and tell people what Ebola looks like so that they can report any suspected cases to the village health worker.
Controlling these outbreaks is really a matter of identifying active cases, segregating them in healthcare facilities where the individuals taking care of them are protected from being infected themselves.
Now, unfortunately, in most of the places where this outbreak occurs, healthcare workers don't have gloves, don't have gown, so they're getting infected, and the first response during an outbreak is to train, to provide the equipment and to train the people how to use it properly.
One of the most important places where people can be infected by patients other than the hospital is through burials. So when people are buried in a lot of countries in Africa, there's a ritual sort of cleansing of the body and preparation for the funeral, and that can really transmit disease to a lot of people.
If you have an outbreak situation, it's obviously it's very important to make sure the human aspect of it is taken care of. You want to stop the spread of the disease in the human population, and that's what we're here to do. If you left it right there, that really doesn't solve the problem. You don't know what happened to start that outbreak initially, what kind of behavior that the human was doing that made him sick to begin with.
75 to 85% of emerging infections are zoonotic or vector-borne in nature, which means transmitted from animals to people, or vector-borne, transmitted from things like mosquitoes or ticks. The Special Pathogens Branch is responsible for all aspects of responding to these high-hazard viruses.
I'm in charge of a small ecology unit within the branch, and the purpose of that unit is to investigate the circumstances surrounding the spillover of zoonotic disease pathogens into human populations.
Finding the natural reservoir host for Ebola and Marburg viruses, I mean, ever since they came onto the scene in the late 60s and mid-70s, I mean, the question's been out there. Where do these viruses circulate in nature?
So we start doing sampling of the immediate environment, and if we don't have any idea, not a particular animal to focus on, we'll kind of do a broad sampling scheme. We'll set rodent traps, we'll set insect traps, we'll try to net bats, anything we can get our hands on.
We had good data from previous ecological investigations that this species of bat, Rosetta's aegypticus, is likely, a reservoir host.
We're getting closer to this huge discovery on the reservoir host, but yet there's still so much more work to be done. It's kind of a never-ending process, and that's one thing I love about science, is that you're constantly learning something new.
We cannot just look at what's going on with people. We need to look at people, animals, and the environment, and look at where those intersect, and this is where we need to work to protect the population.
We live in a world of technology, and there is a huge amount of technology that is focused on our health. The evolution of technology and wellness programs has really escalated over the last few years. Employers are motivated to implement wellness programs for a variety of reasons. Certainly managing healthcare costs is still a big concern, but increasingly, and especially as the younger generations have come into the workforce, there's been much more of a recognition that you really have to look after the well-being of your employees. A health portal is a comprehensive tool that offers a variety of different types of resources to your individual program participants. One of the real benefits of a portal is that it provides a lot of administrative tools. So it can provide event registration, incentive program management and tracking, and a variety of different types of tools that focus on communication. So there's good news and bad news about health apps. The good news is there's a whole lot of them. The bad news is there's a whole lot of them. You don't find what you want on the marketplace, and you might decide to develop a custom app for your own workforce, which is a great option because then it's all about your team and what your team needs. Wearable devices are very popular. Many health portals support a lot of different types of wearable devices. One of the real advantages of social media is that a lot of people use it. It can be used for both content, to deliver content about your program, communications, and also for the purpose of bringing people together. You know, the whole point of social media is to be able to create connections with people. And as human beings, we're wired to be connected. The place we often see resistance from employees in the use of technology in a wellness program is that you're asking them for personal data in some cases. And in some cases, you're actually asking them for personal health information. And as we know, personal health information is protected. It is a tough balance to be able to make sure that you can accomplish what you want to in your wellness program, and at the same time, honor and respect the wishes of your workforce. So sometimes the way that is done is by using a third party as the intermediary for collecting of that data. And that way the employer doesn't actually have direct access to the data, and that employees can feel that there's a bit of a firewall there that would protect their individual data. When we think about value on investment with regard to wellness programs, what we're really looking at is how the program is providing value to the organization beyond just the measurement of changes in medical costs. If you are trying to attract high-performing workforce, having a wellness program and using that to attract employees to come and work for you, that has a very high value to the organization. The program is more than just the technology itself. It's the goals, the objectives, it's understanding what your interests are of your workforce, what their needs are, and what policies you implement in the workplace that support and encourage healthy lifestyles and encourage well-being associated with all of that. So think of technology as a tool, not as the whole program.
Antibiotics aren't always the answer. You have a cold, or it could be the flu. Whatever it is, you just want to feel better. You head to the doctor to get antibiotics so you can get back to normal life. Not so fast. Antibiotics save lives, but many times they are prescribed when they aren't really needed, and that's a problem. When you're given antibiotics when they aren't needed, they won't help you, and the side effects could still hurt you. Those side effects can include a rash, dizziness, nausea, diarrhea, yeast infections, and an infection called Clostridium difficile, also called C. difficile or C. diff. Some antibiotics, called fluoroquinolones, have special warnings about severe side effects. These powerful antibiotics are often prescribed even when they aren't the recommended treatment. Not only can antibiotics cause side effects, they also can lead to antibiotic resistance. Antibiotic resistance occurs when bacteria no longer respond to the drugs designed to kill them. This can make future infections harder to treat. At least 2 million Americans get infected with antibiotic-resistant bacteria each year. antibiotics do not work on viruses, such as those that cause colds and the flu, bronchitis, or runny noses. Antibiotics are only needed for treating certain infections caused by bacteria. Antibiotics also won't help some common bacterial infections, including many sinus infections and some ear infections. When you have an infection caused by bacteria and your doctor prescribes antibiotics, take them exactly as prescribed. Talk with your healthcare professional if you have any questions about your antibiotics. Stay healthy and keep others healthy by cleaning hands, covering coughs, staying home when sick, and getting recommended vaccines, for flu, for example. Improving the way we take antibiotics will help keep us all healthy and will help fight antibiotic resistance, so these critical drugs are available for years to come. To learn more about antibiotic prescribing and use, visit www.cdc.gov/antibiotic-use.
Eating healthy is important. The foods and drinks you choose for meals and snacks can help you be healthier now and in the future. And it's more than eating one healthy meal or one healthy snack. Your food choices add up and they all matter. So where to start? First, choose foods from all 5 food groups throughout the day and throughout the week. Fruits, vegetables, grains, protein foods, and dairy. Your fruits and vegetables can be fresh, frozen, dried, or canned. Try roasting or steaming them as a healthful option. Try starting your day with whole grains, like oatmeal or whole grain cereal. For extra flavor and crunch, add your favorite fruit or a handful of nuts. Stuck in the same old routine? Mix up your protein foods. Try seafood twice a week. And enjoy milk and yogurt in recipes or on their own. Read labels and ingredient lists to compare foods and choose healthier options. Across all of your choices, drink and eat less sodium, saturated fat, and added sugars. And hey, we know it's not always on a plate. It's about making shifts no matter where you are. Start with small changes to make healthier choices you can enjoy. Small changes add up to big wins. For more information, visit choosemyplate.gov.